I have a published paper on PubMed with 10-year follow-up. It's the essential protocol that I followed on a daily basis. I do 2-3 cases like this nearly every day. So there are much easier ways, there's immediate. The problem really is that I want 99.4% successes, which I've got in my published paper, of cases to be successful. And success is something that is over a longer period of time. And this is when I feel that sometimes when we do immediate cases, yes, we get a better short term, but we may have issues because we haven't seen exactly what's going on deeper down over a longer period of time. And that's why when we look at cases, I always sort of look at medium term being 10 years, longer being 20 years. And I have a follow-up on this because I've followed the same procedure for nearly 20 years now. And this is the basic principle of an extraction, and you can see this on PubMed, leaving the case for 3 to 4 weeks, then place the implant and graft, even if the implant has a lower primary stability, as long as you're not planning to immediately load, and then loading at 10 to 12 weeks. The reason why I say 3 to 4 is it depends on your ability to handle soft tissue. So start off with 4 and then load at 12 to start off with until we understand our skills and our variation of the techniques involved. So when you look at ethos.dental, you will notice that many different techniques are used by different dentists, and there's a lot more immediate work being done. What I would like people to start with is what I call a protocol case. So you've had the tooth extracted and it's been allowed to heal. Why have the tooth extracted and allow for this 3-4 week period healing? Well, first of all, we get a soft tissue period of soft tissue healing, and this allows us to get some form of closure of the site. This increases the success of the graft because this means that the patient healing is done in a confined zone. If we leave it open and we graft and we leave it open, yes, that can work as well with healing by secondary intention. The problem is that the patients then leave the practice, ignore all the advice you've given them, go to the pub, have a good time, and we can lose graft material. So I'm following the protocol because I know that my cases over a long period of time get over 99% success. And this is the way I want you to start off, getting a high success, being really happy with the outcome for both your patient and yourself. It's really important to start before we start doing adventurous cases. I hear a lot of dentists saying, oh, I used it for the first time on this peri-implantitis case. And you know, I don't like the idea of doing complex cases where multifactorial aspects can come into play, letting the soft tissue heal, as I say, for coverage. Why 3 to 4 weeks? Well, as we know from all the research by Agaloo and Schropp, Lars Schropp, great guy from Denmark, and you know, they've done lots of research about hard tissue modeling. And what we've noticed is that the modeling starts at a 5-week period. 5 to 6 weeks, we start getting hard tissue modeling. This is why it's important that we actually get the implant in and the grafting done before that, so that we retain the optimal amount of host bone. By placing the implant, which upregulates the host response to host bone healing, then placing the graft, which forms a scaffold, also upregulating the host healing. And then at this period as well, we should have some form of soft tissue coverage. So this just gives us that higher success rate, and that's why this is where I'd like you to start off with. How do we look at flap design? Well, I like to start more from the palatal aspect or the lingual aspect. If you've got the skill and thin blades, we can do a split thickness flap initially on the palatal aspect, going to a full thickness. Then this allows us to not get full closure, but still have a slight bit of gingival tissue over the area where the incision is, if you can imagine what that's happening. So what often happens is that effectively by making the incision more on the palate, we're effectively moving keratinized tissue more buccally when we suture it closed. If it doesn't get full closure, it's best to leave the space which will heal by secondary intention over the palatal aspect. Then we make an incision. Now, if we have good bone on the adjacent teeth, then we always leave the papillae. So we do papilla sparing incisions. And this is well documented. Dennis Tarnow has got a very good paper about this if you want to read it. It's well documented. And what that does is by leaving the soft tissue over the papilla, it's keeping the blood supply to that thin bone on the adjacent tooth. So it's important that I always like to follow this protocol. Then we make a slightly fanning out incision. And again, we don't make a big releasing flap. Now, people say, why? Well, we're not going to place 5 different graft materials, and we're not going to be putting a massive volume in, because what we are doing is regenerative dentistry. We're not doing, in these particular defect cases, we're not doing augmentative. We do not need releasing. Releasing just severs the blood vessels, impedes the host healing, and it becomes more painful. You know, if you release it very high up and your nurse has got the periosteal elevator. And the concept here is reduced surgery and reduced pain to your patient. So when we raise this flap, we'll then often see a defect in the buccal plate. And this is often the case in these upper cases. As I say, especially on the canine, when a referring dentist who's often taken the tooth out takes a canine out, he is guaranteed to take that buccal plate with it. It's just, we all know this, and this is what's going to happen. So then we raise the flap, and the important aspect secondarily after that is cleaning the site, right? A lot of these teeth are very infected. They've been taken out for a reason, and they're not taken out generally because, you know, yes, we may have the occasional traumatic case, but generally there's a reason, and that is infective site. So it's important that we degranulate and clean the site properly. But this is another benefit of this 3 to 4 week procedure, is if we're doing immediate, we often can't see fully down, and we're not cleaning the site properly, and this is one of the areas of failure, is the fact that the macrophages haven't had a chance to clean the site themselves. So leaving it 3 to 4 weeks lets the host actually grow soft tissue over, it's before hard tissue loss, and it's given the host an opportunity to clean the site of the acute infective site, and this all helps to improving our success rate of the case. Once we've cleaned the site, and I like using Ethos degranulation burrs, once you've used them once, you will understand. You will end up with a very clean bone, bleeding bone site, and you can see it, and that's really important to do this aspect. We can then do the osteotomy. As I say, in the bigger defects, like the case I'm going to show you, start off with a smaller defect, but this case shows it quite clearly. And we're not building outside the profile, so it's a good opportunity and a nice starting point to just be doing a traditional bone defect with implant placement. Then I actually like to place a little bit of wet mix. Now people often get confused, wet mix, dry mix. How do I do it? Well, I actually often divide the syringe into 2, and I can mix them in a dappen dish, or I can keep half the material, which I'm going to use for the dry mix, in the syringe and take half out or a third out, making a wetter mix, which means that we apply more saline. Now, when we over apply saline into the Ethos material, do not over wet it and then draw it out with a sterile gauze. This may actually take some of the calcium sulfate out, and this impedes the action of the material. So just add a small amount, but not overdoing it, so don't flood the site in the dappen dish. We then have a mix that's slightly wetter, which we place deeper into the site. This is often to get to the more palatal aspect, because once we've put the implant in, it's harder to get to any palatal defects or to get the graft material behind the implant. So if we place a slightly wetter mix, put it more on the palatal aspect, then we place the implant to the correct level. If we've only got 2, 3, 4 threads in and we have a lower primary, for me it's not a problem, but again, let's start on an easier case where we have a smaller defect, therefore we can get very high primary stability of the implant. Once I've placed the implant, we then take a little breather and we then mix the dryer mix. Now, how to make a dryer mix is simple. We just add very little saline. just enough so that it becomes a paste. The easiest way to do this is to place the saline onto a spatula or a boozer or anything, and then you just add it little by little until we have a nice paste mixed. Or you put as little possible into the syringe, but then mixing it with an instrument down the syringe to make sure it's mixed properly, then draw the excess out with a sterile gauze. We then bring this material to the site and then place it over the top of the implant. Right, this is an important thing, is to not overgraft. We are doing regenerative dentistry, we're not doing augmentative. And as we're not actually putting a lot of material in, we can actually then get a better closure, because the key to this healing is the periosteum. So we want to keep the periosteum closer to the side. In other words, on the graft material, so that it's actually going to allow the body to do this healing and get this upregulated healing whilst the graft material then bioabsorbs. I know a lot of times people look at an x-ray after 2 to 3 weeks and think, oh, I'm losing the graft. No, you're losing the calcium sulfate element. Now, losing this calcium sulfate element is part of the joy and the trick of ethos, because this allows a space for neovascular ingrowth into the newly forming bone, which then leads to upregulated angiogenesis and upregulated osteogenesis. So this is an important aspect. So don't overgraft, because it makes getting tension-free closure more difficult, and it leads to us having to have more difficult getting the periosteum closer to the site. So in this case that I'm going to show you, you'll see the optimal amount. Try not to cover over the head of the implant with ethos, because again, this will mean you're going to have to dig the implant out of new bone when you come back, which is going to be the case in this implant. So the important thing is then tension-free closure. As you can see in the case, you'll notice how the dryer mix that we place on literally sticks to the instrument, so it gives it much better handling when we're placing it in, or if you're taking it from directly from the syringe, it'll then form like a nice ball of material, a nice cylinder of material. We then suture closed. I start at the first suture, I start at the papilla, and as you can see on the sutures, it's got a slight angulation from the flap to the attached keratinized adjacent tissue, and that helps pull that up, and it's like the equivalent of having a mattress suture. So it takes the tension more to the higher part of the flap, and then it allows me just to lay the flap onto the site and then suture closed. I prefer PTFE now. I use Coroflom from Poland, and I find the materials are very nice. There's no attachment of plaque and bacteria to the sutures, and they're very easy to tie and use. I then put 1 or maybe 2 sutures on the palatal aspect, and we can often leave it open on the palatal aspect. We've done a lot of research on healing by secondary intention, and we have histology of the soft tissue of healing over the stable graft material by secondary intention. So that then leads to a nice healing. I can take the sutures out after 3, 4, 5 days. It just varies from case to case, but I normally take them out after 4 days, and the healing has been very impressive by then. And again, I think it's the calcium sulfate element that leads to this improved healing. And this is something they've noticed for 125 years, that calcium sulfate has been used in medicine. These are one of the real benefits of using calcium sulfate as a material. I then allow it to heal and allow the host to regenerate the bone in 10 weeks, but when you start off, just leave it a little longer for 12 weeks. The problem really with the graft material is we often get really good bony growth, so you'll find you're going to need a round burr to access the implant, which is something that happens very often. In the case we're showing, you will see that yes, it looks healthy, you can see the new keratinized tissue, you can see the side, but we still need to improve that soft tissue, and that's why doing it using the protocol gives me a second bite to work at this, so I can use healing caps to again shift some of that nice keratinized tissue from the palate more buccally. And that's what I'm going to do. And so you can see I've just raised a very small flap. No releasing here, because all we're going to do is, using healing caps, move the tissue a bit more buccally. When we raise the flap, you can now see at 10 weeks we can't see the implant even, due to new host bone. Hence we're going to need a round burr. And here it's just a small amount of bone that needed to be taken away to expose the healing cap. The good thing in this case as well is, once we've removed the healing cap, you can see the new host bone, you can see how the site is healed. We've now got 3 to 4 new millimeters of buccal bone. If you look very closely at the flap being raised, you can see blood vessels coming out and tearing away. And this is the important thing, and I think this is why the soft tissue improves, this is why the bone improves, because this whole thing of ethos, the whole ethos of ethos, is healing, host healing blood vessels, and this is something you notice very well. So when I'm placing a healing cap here, initially here I probably put a narrow healing cap, let it heal, and we can use a wider healing cap to get a good emergence profile after a period of time without having to push the buccal gingiva too far away. I then suture it closed again with PTFE around, and I like using Blue M gel over the top. You've got to be a little careful about, a lot of people, like I see people, especially more dentists and more prosthetically driven dentists, often putting temporaries on and changing things and change. Just be careful. Always use Blue M gel or letter mix paste when you're taking abutments off, healing caps off, putting them on again, because we have very new bone and sometimes we can reintroduce bacteria into the site. And I've seen a case on our case studies showing that, and it happened to me the other day, the first time in like 20 odd years. And somehow I introduced something and it was a bone chip, and it led to a little bit of loss of bone in the side. So I had to regraft, but you know, the case is all turning out well. But these are things to always be aware of, is that you have a very fresh bone site. Be careful about introducing bacteria. And then finally we look at the case loaded 6 months, and you can see now where we've taken it from. We just work on the hard tissue and I let the body do the soft tissue. This is the key about this process as well, is that by allowing the body to form true host bone, you must remember all our studies again show that at 10 weeks, at this period, we have over 50% new host bone and only 10 to 12% residual graft material. And this is an important thing, and this residual graft material over a period of time, which is dependent on host physiology, so it can vary, this graft material then fully bioabsorbs, so all we have is host bone. This is a very important factor for host physiology, not just for an ethical standpoint for the patient, but it allows the bone to turn over when the implant is in function. And this is called functional remodeling as well. And what we often notice is that the bone height grows 2 to 3 millimeters or 1 to 2 millimeters in the first year, and we see a much better looking case in years to come. And this is the big difference with these regenerative procedures. When we look at them 5 to 10 years later, they look better than we think. And this is exciting for us as dentists, but it's also nice for the patients. And it allows us to assess the case long term by just taking an x-ray. This allows us to evaluate what is there truly, not just an x-ray of something hard, because the material we've put in is gone. So everything we see, whether it be a CBCT or a normal PA, whatever we see can only be host bone. And this is the joy of being introduced to true bone regeneration with ethos. So I hope this basic conceptual idea of what we're doing on a basic case has fulfilled your ideologies and fulfilled your demands and your needs. And we will look into more in further cases, and in further videos we'll look into more complex cases.